Let us continue. Indicate if you can hear me. All right. So we're gonna be looking at a more condensed version of the chapter with more visuals, but it's the same concept. All right. Extremity trauma. So extremity trauma can be distorted, or the wounded extremity can look graphic. Don't allow this to distract you from life-threatening injuries. Because they are graphic, it's easy to identify. They are disabling. Rarely, they are immediately life-threatening. However, they can be limb-threatening, which is neurovascular compromise, or it can be life-threatening, which is as a result of hemorrhagic shock. So extremity injuries include your fractures, dislocations, neurovascular injuries, sprains, and strains, and we spoke about compartment syndrome in the previous PowerPoint. A fracture, which you know is a break or a chip in the continuity of a bone, can be caused by direct, indirect, twisting, and high energy forces. The dislocation is when the joint exceeds its normal range of motion and the bone separates from the joint. Neurovascular injury is the nerves and blood vessels being compressed by the fracture or the dislocation. Sprains, partial tearing or overstretching of a ligament. Strain, partial tearing or overstretching of a tendon or a muscle pull. Fractures can present as open, which is a compound fracture. So there is communication to the outside. The danger of contamination exists. Blood loss can occur outside the body. You have to control the blood loss and you have to stabilize the fracture. Closed, simple, no communication to the outside, no danger of contamination, no blood loss inside the body. Sorry, the blood loss occurs inside the body. Hemorrhagic issues with fractures, specifically the femur fracture. So the femur fracture can be life-threatening. Patient can lose up to 1 liter of blood. If they have bilateral femur fractures, that's definitely something for you to be concerned about. This can occur in motorcycle accidents where the patient goes over the handlebars and it snaps the femurs bilaterally. With the pelvic fracture, it's far more severe than the femur fracture. So closed pelvic fracture, extensive bleeding into the abdomen and retroperitoneal, which would be behind the peritoneum. Usually fractures in several places. It's 500 cc or 500 mils per crack. May lacerate the bladder or large pelvic blood vessels. Dislocations, neurovascular compromise is what we worry about. It's a true emergency. Though not life-threatening, check PHEMS, distal to major joint dislocations. So this is a limb-threatening injury. Management. No neurovascular compromise, splint in the position found. Neurovascular compromise present, apply only gentle traction in effort to straighten. Often best to pad and splint in the most comfortable position and rapid safe transport. And of course, you must be guided by medical direction and protocols. For your neurovascular injuries, nerves and major vessels run beside each other in the flexor area of major joints. So it is important that we evaluate the pulse, motor nerves, and sensory nerve. And in this picture up here, that's where you would find the dorsalis pedis. That's the pulse that you would want to evaluate. If located, take something to mark the area. If you can't find that one, then you go for the posterior tibial, which would be right here. Sprain, injury to ligaments of a joint, there will be pain and swelling, treat like a fracture. Strain, injury of the muscular tendinous unit or tendon, pain and swelling will be present, treat like a fracture. Now your patient assessment, mechanisms that you need to consider. Falls, landing on the feet, then you want to suspect lumbar spine, injury to the foot. Sitting position, they can have direct injury to the knee, indirect injury to the hip. Fall onto the wrist, direct injury to the wrist, indirect injury to the elbow. Fall onto the ankle, direct injury to the ankle, indirect proximal fibula. Shoulder involved, then you need to suspect injury to the shoulder, neck, or chest. And if the pelvis is involved, you should be thinking about shock. Now, your assessment, primary assessment, LOC, ABCs. Address any issues within the ABCs. In your secondary assessment, gonna expose, look for obvious signs of complications. So major bleeding, decap PTLS, check for tenderness, instability, crepitation, that's what the TIC represent. Joint pain, joint movement, issues with joint movement. What is the assessment for the distal pulse, motor, and sensory nerves? Now, splinting. Splinting prevents motion in broken bone ends. It eliminates further damage. It decreases pain. Now, not in all situations, splinting alone will decrease pain. There are some situations in which the patient will require pain medication. Load and go patients, temporary splinting with a long backboard is acceptable. Additional splinting during transport is fine. So don't waste time trying to stabilize a leg or an arm when your patient ABCs are compromised. Stabilize the entire body, do any additional splinting that's required en route to the facility. Rules for splinting: adequately visualize the limb, assess PMS before and after splinting, treat neurovascular compromise, cover open wounds with sterile dressing, immobilize one joint above and below, that's fracture. If it's a joint injury, then you stabilize the bone above and below. Apply on the side away from open wound. Pad splint well. Do not attempt to push bone ends under the skin. If in doubt, splint possible injury. Now, types of splints, you have your traction splint. Mentioned this earlier. Now you get to see what it looks like. This is a Sager traction splint. Here, traction splints. HARE, here. The traction splint is for isolated mid-shaft femur fractures. The Sager is more acceptable than the here traction. The here traction requires 2 persons to apply the splint, and it elevates the fracture, which might not be ideal if you're transporting a patient in the back of your unit. You don't really want that fracture to be elevated, because if you hit a bump or a pothole, a clot can dislodge and end up in the venous system and block the pulmonary artery. Now we have a pulmonary embolism. That's a bigger problem. The Sager, one person can apply it and it can stabilize bilateral femur fractures. So it's more acceptable. All right, now for the spine, you need at least 4 persons to properly immobilize or put a patient on a spine board. Somebody to control the head, somebody to control the upper body, lower body, and somebody to control the spine board. So this particular individual would probably be of more use on this side. The person at the head give the command for the log roll. Once you log roll the patient on their side, you have access to the back. At that point, check the back. You can also assess lung sounds at that point as well. Put the backboard into position, log roll the patient onto the backboard. If the patient is not on the spine board completely, do not push the patient across the board. Move the patient up and down in a straight line until they are centered on the board. Once the patient is on the board, you secure the torso first, then the legs, then the head. So it is torso, legs, head, right? In that order. For the pelvis, you have your pelvic binder, and once you discover an unstable pelvic area or suspected pelvic fracture, you do not release it until it is properly stabilized. Pelvic binder, or you can use a blanket or sheet to stabilize the area, because it's a pelvic injury, or if the patient has bilateral injuries, you cannot log roll a patient with bilateral injuries, so you have to scoop that patient. So a scoop stretcher or scoop backboard would be more appropriate to move this patient. And your here traction, somebody has to apply the manual traction while the other rescuer measures the splint and apply the splint to the injured leg. The Sager, one person can do it. You don't necessarily need 2, right? If you have 2, that's fine, but one person can put the splint on. And it is more acceptable than the here traction splint. For the hip, there are 2 pictures here of a hip stabilization. The difference between this stabilization and this one is this patient is stable. So there is time to do all of this, right? And note that the long splint goes above the splint. There is stability above the hip, sorry. The long splint goes above the hip. There is stability above the hip, and there is stability below the hip. So above and below is stabilized. And as I said, that's if your patient is stable. If your patient is unstable, then you quickly put some padding between the injured leg and the uninjured leg, and use the uninjured leg to stabilize the injured leg, and you quickly move your patient. So this is an unstable patient. This is a stable patient. For the knee, you can use the vacuum splint. So this is what a vacuum splint looks like. It's placed on around the knee, a vacuum pressure is created and it shrinks down and conforms to the limb. If you don't have that available, a pillow and triangular bands can do the same thing. For the tibia and fibula, once it's below the knee, one splint is acceptable, right? So one splint is fine below the knee. At the knee and above, then you want to be using at least 2 or 3 splints above the knee, at the knee and above. Yes, go ahead.
Yes, sir. That you refer to as a back slab.
I wouldn't refer to it as a back slab. I would refer to it as a rigid splint. That's what it is.
Oh, okay, so that one they can't bend. So they really hold it down there, so.
No, it can't bend.
Okay.
That's a rigid splint.
Oh.
All right, now for the clavicle, a sling and swathe is acceptable. Right? That's very much acceptable. For the shoulder, again, sling and swathe is acceptable. The difference is we don't try to move this limb too far upward, right? You're going to try and catch it in the position that the patient is comfortable with, and you put padding between the patient and the injured limb. That's for the shoulder. For the elbow, you can use 1 splint or you can use 2 splints. So there's a way to use 1 and there's a way to use 2 splints. If you're using 1 splint, then you need a supporting splint down here, rigid splint preferred. You want the forearm in what I would call the hammer fist position. So this is a position that you want the hand in. Once they have good grip, always give your patient something to hold if they have good grip. You can use a roller bandage to secure this splint to the forearm. So you use a roller bandage to secure the splint to the forearm, and then you create a wide swathe. So what is happening is you have now secured the humerus and the radius and ulna has been secured. So the bone above and below has been secured. This is our injury point, right? So you want that elbow at a right angle when you're stabilizing it. For the forearm, rigid splint, roller bandages, or triangular bandages to catch the wrist and elbow joint would be acceptable. If there is no deformity, ear splint, so this is A-I-R, ear, not the same as here with H-A-R-E, traction splint. So this would be a ear splint, can only be used for a fracture that's non-displaced. For the hand and foot, again, rigid splint, and note the position of function for the hand, right? So for the hand, note the position of function. For the forearm, note the position of function. If it's the elbow, we want hammer fist, right? If it's the forearm, we want that the palm of the hand pointing downward. For the foot, pillow, roller bandages would be sufficient. Or you can use rigid splints if you have that available and put some padding. And that would be the end of this presentation, right? So, extremity trauma is not usually life-threatening. There are some exceptions. femur fracture, pelvic fracture. Proper splinting decreases further injury, dislocation of elbows, hips, and knees, required careful splinting and rapid reduction to prevent severe disability to the extremity, and you will be guided by your medical director and protocols. Any questions? Let me see if I can find this video. Someone had asked a question about the time. Let me go back and check. The time in the event of an amputation, is there a specific time span to reattach the part? No, I'm going to answer the question, but you shouldn't be asking that question, because the answer to that question is in your bleeding chapter, and there was a recorded lecture that was sent for that. So it means that you have not reviewed that lecture yet, or you have not read the chapter. Anyway, you have 2 hours with your musculoskeletal system. So the musculoskeletal system can go 2 hours without appropriate circulation and perfusion. So you have a 2-hour window where you need to get the patient and the amputated part to the hospital so that it can be reattached. Any other question? Or any question, I should say. All right, let's see if you can put this together practically. So let me open this video. All right. Hold on, that was quick. All right. All right, somebody send some. There's no specific scenario for you to use a flexible splint. You use what is appropriate. So it's based on what you want to achieve. So I would more want to go with a splint that is formable if I cannot realign a limb. So if I can realign the limb, then I would probably go more with a formable splint that I can manipulate. But I will not say to you that there is a specific scenario in which you would use a flexible splint. You use the splint that is most appropriate. What is important is the fundamentals are maintained. So I don't need a splint to stabilize a patient's limb. I can use a patient's body and stabilize his arm. So if a patient has a fractured arm, I can use his body to stabilize his arm. I can use his good leg to stabilize his fractured leg because I know the principles. I can use a magazine, cardboard. I can use a broomstick and 2 belts because I understand the principles, right? But you're gonna gravitate more towards formable splints when you cannot realign a limb, right? So, and more for your joint type injuries where you have flexion. That's where you want to be thinking about formable splint. Now, the ear splint can specifically be used for a straight fracture of the forearm, right? That's the only fracture you can use an ear splint for, and it's a formable splint. So that's why I'm saying to you there is no specific criteria. You just need to analyze the situation and decide what is the best approach right now. And whatever approach you're using, does it meet the fundamental principles? That's it, really. All right. Let me share this video. Everybody seen the video? Nobody can see the screen. I don't start to play the video yet. All right. So watch the video. All right. All right, let's watch that one more time. All right. Let's go back here. Hold on a sec. Let's go back here. All right. So you're at that event providing EMS coverage. You witness that occurred. Walk me through the process. So first, and I want a full assessment. I don't want pieces. I want a full assessment here. So things that you need to consider. What I want you to consider is everything that you have learned up to this point. Every single thing that you have learned up to this point. So I want a scene size up. I want a primary assessment, history taking, secondary if necessary, reassessment. That's the mindset you should have right now. That's how you should be thinking. So starting off with the scene size up, what would I be looking for? Any takers? If something is wrong with your mic, type the things that you would look for in your scene size up in the chat. Go ahead, Mr. Wilson, quickly. Scene size up, go.
Is the scene safe?
Yes, it is.
Mechanism of injury is
What you see as the mechanism of injury?
so it's a sports related injury. So.
What is the mechanism of injury?
I try to formulate it properly.
There's nothing to formulate. What is the mechanism of injury?
So it's a fall, sir.
Right. It's a fall. That's the mechanism of injury. So the scene is safe. What else you said?
Mechanism of injury is a fall. May I consider possible spinal injury. So see spinal something I consider. Standard precautions, gloves, face mask. Number of patients is one.
Okay, so I've heard scene size of safety. I heard standard precautions. I heard the mechanism of injury was a fall. It is one patient. You mentioned anything about additional resources? I don't recall. Did you?
I did mention C-spine or something what I consider.
C-spine is not additional resources. If you're considering C-spine, you're considering the mechanism of injury.
So ALS would be
Come on, that take too long. Are you considering additional resources? Yes or no?
Yes, sir.
All right, moving right along. Now, is there anyone that disagree or agree with what Mr. Wilson just mentioned regarding the scene size up? Yes or no? So if you agree, raise your hand. If you disagree, keep your hand down. What about the rest? So the others that disagree, that I haven't seen your hand go up, what is absent or what you would consider that Mr. Wilson has not? Miss Cephas, your hand didn't go up. Tyrell, Chantilou, Johnson, I didn't see these hands go up. So what else is there to consider in the scene size up? Go ahead.
You touch that one right here.
Yes, sir. Johnson here.
Yes.
So, in the scene size up, we established the mechanism of injury was a fall.
Yes.
Now, with this patient and based on your scene size up and what you can see, that the patient has some great deformity or injury to his left leg. And when he landed, so would request ALS, right? And then based on the injury we can see, look like him have a compound fracture there.
All right. There's no compound fracture. ALS is not required.
All right. So now would again we splinting thing then.
We don't reach there so yet. I am talking about a scene size up, not asking about treatment. So answer the question that you're asked. I don't want you to give me meaningless information. What you're doing is wasting the time of the assessment. Focus on what has been asked, focus on what you have observed, right? Now, in the video, there's no indication at this that the patient hit his head. So yes, you can consider C-spine precautions, but it's going to be a conversation that you need to have with the patient, right? I'm not going with C-spine right off the bat based off of what I've observed. All I asked for is the scene size up. That's what you need to give me. So 1, you make sure that the scene is safe. 2, take standard precautions. Mechanism of injury is a fall without loss of consciousness. 1 patient. Are you considering ALS at this point? It is not something you need to consider right now. It will be based on your interaction. I said you are at the event, so you witness what occurred. So that's your scene size up. Once you have completed the scene size up, what is the next step of your assessment? So the next step is your primary assessment. So how do we go about that? Any takers? Didn't ask anything about psychogenic shock. And what is psychogenic shock? Psychogenic shock is fainting. It's not relevant to what is going on here. Stop confusing yourself. If you're not hearing me, Miss Cephas, it's a connection problem on your end. Yes, go ahead, Mr. Cameron.
So in a primary assessment now, we have to assess the level of consciousness.
Can't be a level of consciousness first. There's a sequence you follow.
Introduction.
Introduction, I
Can't be introduction. So mute your mic. Mute that mic. Anybody else? What's the first thing we need to do in the primary assessment? What's the first task? Yes, Mr. Manning.
Yes, sir. It's to get a general impression of the patient. See what position.
You form a general impression of the patient. So, Mr. Manning, based on what you observe, give me a general impression of this patient.
All right. So, as of what I'm seeing, sir, the patient is in a supine position. He appears to have a fracture on the left leg because they're holding that leg. The patient seems alert. I would have to check their orientation, but the patient seems alert based on the general impression. The patient is also a male.
So give me that general impression again.
Yes, sir. So we have a male patient in a supine position, apparent fracture to the left leg. The patient seemed alert and seems to be ventilating properly, because you have to, well, the patient seems alert. I would have to check the orientation once I get closer.
Okay. All right. Is there anybody else that would have anything different? Nobody else have anything different. All right. So the general impression would be the first thing you do. You need to form a general impression as you approach a patient. It's a white adult male, young adult male, found in a somewhat supine position. The patient does seem to be awake and alert. Patient seems to be in severe pain. There are no open wounds observed at this point in time. There's nothing harmful in the environment. That is a general impression. After you've completed your general impression, what is the next step? Okay. How would you obtain the patient's level of consciousness? Not you. Yes, I'm waiting for the others. Using the AVPU. Okay. Miss Wellington, Miss Cephas, who is that? Mr. Terrell Chantilou Johnson. How are we going to ascertain the patient's level of consciousness? I don't know what AVPU means, so you need to write out what you're talking about. What does AVPU mean? Yes, go ahead.
Yes, sir. So we are check for the patient level of consciousness. And Jason, know you have the interaction with the person. I will tell them your name, introduce yourself to the person, your partner name, and try find out what really I want.
Okay. All right. Anybody else? All right. So don't just tell me you're gonna you're gonna use AVPU. How are you going to do it? The first thing you do is you introduce yourself to the patient. Then you find out what is the name of your patient and find out what is going on, right? So, hello, sir. My name is Brian Rufus. I'm a medic. This is my partner, Mr. Barnett. We just witnessed what happened. What's going on? How are you feeling right now? What's going on? Talk to me. What's your name? Right? Patient tells you that boy, he hit the board at an angle that was not adequate. And when he fell, he came down at a bad angle on his leg. And he think he may have broken his leg. He's convinced that his leg is broken and he's in severe pain right now. So that's what the patient communicated to you. Now, based on that level of communication, what are your assessment findings at this point? All right, so let me see what is. All right. So Powell, conscious male patient. Oh, that's general impression. Michael Wilson say LOC using AVPU. Powell, AVPU. Miss Wellington, my communication. Again, people, you need to be specific, right? We're not gonna go to the patient and say, sir, what is your AVPU? How do you obtain that information? Terrell say assess long-term memory, short-term memory. It's not as complicated as that, but yes, you are correct. You are correct. Michael Wilson, you're still not saying much, dear. I know what AVPU means. How would you obtain the information? All right. Mr. Chantiloop, good. So Mr. Chantiloop say he would introduce himself, ask his name, age, how he's doing, what's happening, what do you feel, how are you feeling? So that's what I'm looking for. Now, as I said, based on the patient's, let me wait for my signal to go back up. Matter of fact, let me